Good morning and welcome to our monthly webcast. I am Samir Mehta, your host. This is session number 43. A very happy new year to all our listeners across the globe. We have another extremely technically challenging coronary complex case of unprotected left main, which we'll start demonstrating in just a few seconds. In the meantime, let your questions keep coming. info@ccclivecases.org. For our Chinese viewers, please go press on the click button on the Chinese webcast and you shall be able to see it. Samin, good morning. All set in the cardiac cath lab. A very happy new year to you and to your team.
Well, happy new year to you and to our global audience and our partner CardioSource and ACC. Has been a tremendous year for us in the sense that last year, while with the various efforts and of course the great results, the highest total interventions at Mount Sinai was 5,800 in 2009, which we broke our own record by making it 5,806. So the 2009 was 5,800 and last year in 2012 were 5,806, definitely up. Coronary intervention remain about the same. It's a growth basically in the structural heart disease and endovascular. And of course my cath lab working all midnight 3 days a week at least, past midnight and Sundays, has helped us to achieve that milestone.
Samin, a quick follow up on that. What are the volumes for the cardiac surgery?
Cardiac surgery, I think we're still getting it, but the ratio of PCI versus CABG at Mount Sinai is about like 13 to 1. So we do about 4,730 PCIs and CABG was about like 370.
How does that compare to New York State and probably to the
Yeah,
rest of the country?
I think the more and more places the ratio is becoming about, used to be like 3 to 4 to 1, now about 5, 6 to 1. Many centers actually is lower, but I would say about 5 to 6 to 1 PCI to CABG ratio is the usual. Sinai is little anomaly, but part of that is big or major part that patients are coming here for intervention and selectively, and many actually, if I say that how many patients to us referred by the surgeon from outside, will be at least 100 cases which will come to us referred to us by the surgeons from outside Mount Sinai. So that these are the real complex cases. We have established our reputation and doing them well with extreme safety.
Excellent. A quick another follow up to your introduction. This is session 7 since our partnership with ACC. What do you think have been the notable improvements?
I think it's a superb. Lots and lots of any meeting you go, more visibility. And now this month we starting CME for the archives and hopefully live within next few months. So that has been a tremendous partnership, and this is something which we continue to evolve and make it better and better.
And the viewership is increasing in mainland China and in other parts of Asia.
Absolutely.
Anu, good morning. Would you start by taking us through the case?
Okay. So now, but this if we can get to the slide and I'll get to the little history, the support of all which have been supporting our this webcast are here: Abbott Vascular, Boston Scientific, Medtronic, and Daiichi Sankyo and Lilly.
Samin, to clarify, that's a straightforward educational grant?
Yes.
All right.
And these are our disclosures which are always available for all of us. And taking to the case, as you said, case number 7 with new partnership with 68-year-old male, presented on 12/28 with crescendo angina class 3 and had stress MPI earlier last year, revealing mild inferior ischemia. So he was managed medically, had mild ischemia, then end of last year presented with the class 3 angina. Had a cath, and which will show had a 3-vessel CAD and left main with a good LV, high syntax score. Therefore, patient was recommended with a young age, no other comorbid condition, CABG, which is a routine treatment for this patient with a high syntax score and so. But patient declined, went home, was increased on medications, and these are various risk factors and the medications. And this is the angiogram, and actually we can get right to the angiogram by Anu, starting with the LV, which is normal.
Yeah, LV is normal. You see here. This is RCA. There's in the mid RCA about 80% disease, but more important is distal RCA to AV continuation is totally occluded with some bridge collaterals, and this is what we see in the left main, long left main, moderate calcium, but distal left main about 70 to 80 extending into the LAD, and this is how it looks in the caudal view. You see it's an eccentric lesion, that is why you do not see the distal left main lesion in the caudal, but you can see the circumflex disease as well as the LAD disease, but more important there is the hilateral, which the osteum is not involved angiographically.
But
So
by
it's the moderate
definition, yeah, but by definition, remember with the syntax, this we still will call trifurcation, and of the 4 segment of the trifurcation, distal left main, ostial LAD, ostial circ, ostial rim, hilateral, it will be 3 segment involved. So if you have all 4, we saw it. Even if it's a mild to moderate calcium, it gives you syntax score of 33. Since the ramus is not involved, the syntax score in this particular case is lower. But key is that it's right away that trifurcation with of the 4, 3 segments involved. Then.
So the question is, how do we handle this case? Do we do the left main first, or do we do the totally occluded RCA first?
Anu, before that, another quick question for Samin. The patient is a diabetic?
Non-diabetic.
It's non-diabetic.
Non-diabetic, all right.
Yeah.
So we keep the applications of the freedom trial out at the moment for evaluation.
Yeah, absolutely, and that actually will be one of my question also, because in the freedom, the left main was excluded, but clearly that with the multivessel disease and multivessel with the left main, we know the multivessel did so well with the CABG in the freedom. With your multivessel and left main like this case, I'm sure the freedom, if would have done in these kind of situation, would have been even much better in response or in favor of CABG. Okay, so therefore basically what we did is we took the patient out, referred to surgeon, discussion with the surgeon and the cardiologist. Patient still decided no surgery because has some uneventful experience in the family, went home. Then we had a discussion again, rather than leave this patient alone without any treatment, and clearly this is where I'll go with the guidelines, that after your discussion, after patient given all the facts that this is CABG is the best approach, patient may still decide, and then of course you end up in doing the intervention. But key is decision not to be made on the table in a hurry and give it. It's not an ad hoc PCI. Very important. We do Cath possible or ad hoc PCIs, which is a routine treatment at present. But in a complex cases, ad hoc PCI should not be done. And that's where I would say that we as an interventionalist having a bad name, that we tell the patient lying on the table, do you want a stent or do you want your chest cut open, and put them in a very precarious situation, and of course majority of the patient will say go for a stent. So therefore this discussion with the patient, with the heart team and surgeon and plus minus cardiologist has to take place outside the cath room, and that is what happened in this case. But despite all, patient elected that not going for surgery and came back here for intervention today.
So, I mean, this is a syntax score 33,
yeah.
Genuinely a patient who I am sure most physicians will refer to cardiac surgery. Take me into the process. Who spoke from the interventional cardiology team with this patient?
When Anu did the case, we told the patient, she did, that you need surgery. We are going to discuss outside. We took the patient out, called the surgeon and the patient's cardiologist. They all had a discussion. So that happened on the telemetry floor with the plan, because since it was done on 28th, which was Friday, idea was patient stays over the weekend and should have had a surgery on 31st December. That's the way we planned on 28th when case was done.
And the patient went home, thought about it and came back requesting PCI.
Yeah, patient refused and patient went home, then said, well, I want to go home and think over this new year, but we told him to restrict his activities, up his beta blockers and so, and then further discussion took place. They actually came to see Anu with the wife and so,
as appropriate as it gets. Thank you for clarifying that. A large amount of patients behaving in this fashion.
Well, I will give you actually data in the end of our syntax this trial, the syntax memo or the protocol which you have established and how we are now. Yeah, but it's about half. Yeah.
I think if a cardiologist is involved and he is in-house, I would say essentially the discussion has to be led by the non-invasive cardiologist rather than putting interventionalists and surgeons on the scene. Our surgeons and interventionalists should come after only after the cardiologist has discussed the case, because you know, he is unbiased and give the right opinion to the patient. But many times, you know, some of these patients come from tri-state area. If the cardiologist is not around, that is a situation. We discuss the case over the phone with them, and many times they will go to their office, but before they go, they would definitely have had a discussion both with the interventionalist and the surgeon before they leave the hospital. Then the discussion will happen in their office, and decision will be made, unless it is a critical disease that we know patient cannot go, cannot be discharged from the hospital. In that situation, it will be the decision made by the interventionalist, cardiologist, and in-house the surgeon, interventionalist, and the in-house cardiologist will be assigned, and that cardiologist will take a lead in the discussion.
Excellent.
Okay, and tell us also what's your plan now. Clearly, therefore, this is the appropriate case with such a complex coronary anatomy. There is no question, and that's where. Now tell us what you want to do, and then I'll go through my lecture.
So after the extensive discussion with this patient, since at any cost we would not want to go for surgery, we decided we will approach the left main rather than the totally occluded RCA first. And if you see here, there is moderate calcium, but most of the disease is in the distal left main, bifurcation extending into the LAD and circ. So I think we plan to do rotational atherectomy from the left main into the LAD. Since it's eccentric, we want to make sure there will be a good stent expansion. And then once we do rotational atherectomy, then just do balloon. If there's a good expansion with the regular balloon would be good, otherwise we may have to do a cutting balloon to the circ and do 2-stent approach. We of course will do IVUS at the just with the diagnostic 6 French Cath. There is a lot of damping at the ostium of the left main, if you see that. So yeah, even if we have to take care of the ostium, we may have to just do a separate stent. Yes.
Is that because of some disease or a long left main, or just a little eccentric plaque there?
I think there's eccentric plaque.
Okay.
At the ostium of the left main. Yeah.
But I think this is an ideal case where you need to explore this by doing intravascular ultrasound. I mean, not every case you need to, although left main you can make it a point of doing a ultrasound. So that's where Anu will do, getting a 7 French guide in, knowing that it could be a 2-stent case. We want to do 2-stent in this case because of large vessel, and we'll come back to while I finish my the presentation, so that we'll just wait about 10 minutes. We go through our slides, and then we'll come back what has been seen on the IVUS and what will be our plan. So if we can go back to our slide, the 2 points today which I want to make it, which is appropriate for this case. One is the unprotected left main revascularization trial. Second is the current guidelines for complex multi-vessel and or unprotected left main CAD. This basically kind of continuation of what we had with the freedom trial last month, and 2 months ago with the syntax. Basically put things together, an emphasis on how these patients should be discussed, how these patients should be planned, not to worry about that whether you can do a stent or not. We all know you can do a stent in any case and with a great success. But the whole question comes is that how, what will give the long-term benefit to the patient. Now therefore, first is the unprotected left main. Clearly we know the majority of the cases like this, 2/3 are the distal bifurcation, and they create more problem. About 25% at the ostium, which have been shown that ostium and body shaft lesion of the left main behave totally different than the distal left main. Distal left main is the one, I would say, Achilles heel of this complex intervention, because those are the one associated with high restenosis, and many data have shown that ostium almost have a less than 2 or 3% restenosis. Of course, the issues are procedural success, acute complication, stent thrombosis, restenosis, and long-term follow-up versus CABG. We actually lot of data with the drug-eluting stent in the registry, and overall average mortality was 4.4% and the TLR of about 11%, half of the BMS trial in the left main, unprotected left main. This is the data of the ostial left main with a long-term follow-up of 4-5 years, showing that ostial left main do extremely well. People always ask, what about the bare metal in the large left main type situation? We have one data from Australia. Everyone had a cutting balloon and IVUS, 50-50 cases, paclitaxel versus bare metal, and you can see that in a despite being a large left main, the DES of the Texas first generation did better compared to bare metal stent. And of course, that led to a lot of observational studies and publication, and we have 3 randomized trials, small being the Lehman's trial of 110 cases. Again, it was the primary endpoint was the LV function improvement, which was better with the PCI. Then pre-combat trial of 400 cases, CABG versus PCI from Park, and of course DES, all were identical. And the Syntax trial, which is the largest of the left main so far, of 708 patients, and giving us the data of clearly that at 1 year that you have isolated left main or you have left main with additional vessel disease. Very important that if you isolated one vessel disease with a left main, you have actually see the height of the red bar versus blue, that actually PCI does well. It loses when you get more additional disease of the 2 and 3 vessel, as you can see here. Also, then interplay of the Syntax score. What has been shown that once you get to the higher Syntax score, usually means more multi-vessel disease, that you will have a bad outcome with the PCI. Actually, if we can go back to the live IVUS being done, we can just show that IVUS.
So we are at the ostial prox ostial LAD. Yeah, coming to the left main.
Can we switch to the IVUS pictures, please?
Yeah, that's the distal left main. You got the bookmark, right?
And we are going to get to the ostium.
Yeah.
Make sure the guide is out in the ostium.
Yeah.
Very important when you are coming to the ostium that your guide should be out.
Yeah. Okay, that's the ostium of the left main now. Bookmark.
So
Eccentric plaque.
A little eccentric plaque.
Yeah,
but looks
I think
good
we could
human.
leave it. Yeah.
Okay, we can
Could
stop
be
it.
left
Anu,
alone.
you have a side hole guiding catheter?
No, essentially, I think I do not like side hole guide catheters.
Well,
Though,
just
did you want to do circ or no?
We
Let
can
it
do-
run.
Yeah, do the circ also. Now we go to that point of the distal left main with the ostial LAD, very tight bifurcation. If you can see,
That
right
probably
there,
at the tightest
and
point
look at
right
the
there.
calcium, right there. But calcium actually is not a heavy calcium.
right.
It's only eccentric arc, but still there is a calcium. And now Anu will going to do it in the circumflex.
Some die.
Samin, based on what you saw, do you think most people could get away with the cutting balloon there?
Yeah, I would say so, absolutely. This is the case of atherotomy, whether cutting balloon or angiosculp. Go to and see the expansion, and many times these balloons you may not be able to expand completely. So in that case, you may need to go to high pressure with additional balloon. But though I would say this will be completely fine. That we don't need to do a rotation effect in this particular
So
case.
specifically between the two, the cutting balloon and the angiosculp, which one would you prefer here?
Well, I would say in this particular case with a less calcium issue, that probably the cutting the flex dome will give you a better lumen. And if you need to go to high pressure, if you see a moderate calcium, that's where the angiosculp will be used. Now we can see here that maybe the circumflex we use that circumflex we can use the one versus other, although we cannot advance.
A little more, there appeared to be in one of the earlier views a little more calcification in the ostium of the circumflex, although again not so much.
Yeah, I think that lesion is tight, so
Right.
We just don't get.
So based on IVUS information, you will lean towards the cutting balloon.
I would say so, because I don't think with that calcium, knowing that just a little arc of calcium, that we need to do rotational threatening. And what do you say?
It's just that this eccentric, having been done many of these cases,
There's
when you
lot of
see this
calcium
kind
there,
of eccentric, even though it did not see that eccentric lesion in that left main, I think to get a good expansion there.
You are leaning towards the rotablator?
Yes.
Okay.
We've been there, done these cases, and we know that later on we'll have a lot of trouble in getting a good expansion.
Anu, this much angulation and mild eccentric lesion, no issue with the rotablator. Would you slightly downsize or go with the 175?
I think if we want to get a good result here, to get expand, you got to do 175. Even you saw the lumen
with the single burst strategy.
Single burst strategy. Yeah.
Excellent.
Just just go with the slow burring speed, and since it's a short area, we should be okay.
Okay.
But at the same time, I think I would not recommend doing that burr in the circumflex.
Samin, continue with your presentation, but before that, see, we have done similar cases 2 years, 3 years and 4 years ago, where we used to be very concerned how the patient was going to tolerate the ischemia.
Yes.
You don't think it should be any issue that these were the cases we used to put in balloon pumps and impellas? Of course, impella is not needed because of the LV function.
Yeah, yeah. I mean, you're right. In this particular case, question always comes even with the normal EF, knowing that the RCA is total. This patient may develop some hemodynamic deterioration, so that thinking about a balloon pump may not be a wrong approach. But we learned that nowadays with a quick stent expansion, rapidity of the technique, that these cases we can safely do without need for balloon pump. And of course, if you need ad hoc, you can always
If
insert
somebody proceeds and decides to put in just an access sheath from the left groin, is that overkill?
Well, no, I think that probably is the best right approach. And I would say even somebody wants to put a balloon pump in this particular case, in this complex case where you'll use a 2 stent, RCH total, is nothing wrong, because that will give you guaranteed surety, so that you'll get your good interventional results, and that's completely fine. Now we also learned that these cases nowadays we are doing quite well without using of the balloon pump, and so definitely, as you mentioned, that impella is not required because of the good LV function, but definitely in some cases you may end up in using the balloon pump.
Anu, what wires are those?
No, I'm just going directly with the rotawire.
Okay.
Okay, now we can go back here. Now, therefore, we'll take a little time and put a wire, and then we'll come back here. We can go to the slides now. That relationship of the syntax score, clearly that for CABG there is none. Whether low syntax score or high syntax score, outcome, as you see, the red bar is identical. But there is a clear-cut gradient once you go to a higher syntax score of 23 or 33, that the PCI outcomes at the long term with the Texas DES showing higher MACE rate. Now we actually have the 4 and 5 year data on our patients with the high syntax score, and what actually has been shown. You want to show? Let's see the. Go back to the wiring.
So the same issues always with the rota wire.
Yeah, I mean same. I mean you could, but once if you think you cannot.
Anu, I was quite impressed with the angulation when you had the wire in the circ, and I'm sure many people would be concerned with the rotablator, but you didn't think that was much of an issue.
No, angulation of the circ we are talking, or we are talking about the LED?
No, the LED looks to be still a straighter angle, so that is being the
yeah,
target.
but we are not planning to do the rota of the circ.
Right.
Yeah. So if you have trouble, then you need to use this rota clip. That will give you some help.
And you look to have gotten it quite all right.
Yeah, we are in the diagonal. Somehow the wire goes everywhere except where you are supposed to go.
Today it did go the right way.
Yeah.
Okay. Now we can go back to our now slides. That now we actually have the 5 year data presented by Dr. Patrick Soroy in TCT for the left main. Same with a low syntax score. As you can see, the CABG actually had a little higher mortality and other event rate, CV and death with the low syntax score. Intermediate actually not different, and this is different than 3 vessel disease and overall growth. But once you go to the high, very important, look at this now. Intermediate syntax score actually with the left main, CABG had a higher mortality statistically compared to PCI in the intermediate. Once you go to the higher, 33 and so, this was only for left main. While for the 3 vessel disease, the curve separated at the syntax score of 22 and so. So basically clearly high syntax score bad for the left main, and the technique 1 versus 2. This we have said quite a bit. In this case, we try to do a SKS because of the short, the distal bifurcation lesion. Now, this actually has led to our guidelines now. Clearly, the left main disease that with a low CAD burden of 33 or so, that doing a PCI is uncertain but not inappropriate. Only inappropriate is like patients who have syntax score of 33 and above. But those patients, after discussion, sometimes end up having a PCI, as we know. Now, actually, in the European guideline, things are a little more clear, that they make actually many of the left main, particularly isolated ostial left main, as a 2A indication. Now, there is an ongoing randomized trial of the XL with the randomizing patients to the Zions versus CABG in 2,800 patients. Trial actually has enrolled about 1/3 patients. It's a very difficult in the case at present to convince the patients, many of them who come for only CABG, and syntax score, as you see here, 33, less than 33. Very important with a 3-year endpoint, just like the freedom in this trial. The second is what our guideline, and clearly based on the syntax which I mentioned, each individual lesion has shown the prognostic value of the low, intermediate, and high. As in an overall trial, again the syntax gap after that syntax of 23 and above, separation from the CABG in favor of CABG, and PCI having a higher event rate. And these are the 5-year data of the overall, that you can see at the intermediate, the curves start separating very clearly in favor of the CABG, and of course with the high syntax score and so. So clearly that for high syntax score, 3 vessel disease, whether for high syntax score, I would say for 3 vessel is like 23, for left main alone will be about 33, as shown to be better with the CABG compared to PCI. And this actually had put together by last year, year before, our guidelines committees for both CABG versus PCI, that who should get what. And very important, the first time they divided the patients a recommendation based on 2 points. One for survival and second for symptoms, because many times we do things for symptoms, like in 82-year-old, we are not doing it for survival, any procedure, we are doing it for symptoms. And clearly that for survival point of view, CABG for unprotected left main or multi-vessel disease with high syntax score is class 1. PCI comes in as a 2A, particularly when patient has a high STS risk, means high CABG risk. Clearly low syntax score, high CABG risk, higher chances, PCI comes as a 2A. It becomes 2B when we have intermediate syntax score of 22 to 32 and STS mortality is low. And clearly once you have a low risk, then it becomes class 3. So these are basically for the survival point of view. Same thing for the single and multi-vessel disease, that CABG is favored for 3 vessel with plus minus proximal LAD as class 1 and PCI as a class 2B and 2A in many of these situations. Then the symptoms, very important, that we do many intervention not for survival, for symptoms, because we are not talking about patient with acute MI. These are the patient with a stable CAD, and it seems to be, as shown here, that patients who are significant symptoms or ischemia both do better with a CABG or PCI, and many of them have a class 1 indication as highlighted here. But if there is no ischemia, there is no anatomic or physiological criteria for revascularization, irrespective of the lesion, those patients should not get PCI or CABG, because that's a class 3 indication. And of course, as I mentioned, that PCI for the complex 3 vessel and diabetic with a good candidate, the CABG is preferred. And this is the same our ACC guidelines. Actually, European have put it a little better way. In my opinion, this is a very excellent slide. That is put in one slide for prognosis and for symptoms. For prognosis, class 1, first is that you need to do revascularization. Then second, their recommendation is whether PCI or CABG. But clearly for prognosis point of view, left main more than 50%, proximal LAD more than 50%, 2 or 3 vessel disease with impaired LV function, large area of ischemia, single vessel supplying more than 50% of one single vessel supplying the myocardium, all are class 1 indication. And clearly the single vessel with some ischemia less than 10% is class 3 indication from survival point of view. And the symptoms as shown here very clear. So I think these are little better guidelines in my opinion, more clear cut for us what to do. Now for the CABG versus PCI, very nicely illustrated by the various colors in this, that green being for CABG and the various the yellow and the red being for PCI, but it basically puts together that our working algorithm that these patients should have a consultation, because you need to go over the cases. And one important point they do mention, that in complex cases seek an advice and assistance or consultation from the expert colleague. So don't be shy that if the complex case you need to get more experienced people to help you to get the good results. And this is the whole issue about class 1 as a hard team approach and the calculation of the syntax score. Coming back to the point you said, we started this our memo and the protocol of the syntax back in 2011, and now incorporated 23 and above. We actually analyze every case we have high syntax score, and despite the recommendation, this is a fact, that despite the strict adherence to the syntax protocol and the hard team discussion, almost 50% of the patients go for refuges CABG surgery. And this is where the issue is, because of the guidelines are not forcible, means there is no penalty for the patient, no penalty for the institution. We just let the patient decide. But that is okay, as long as, like in this particular case, that you are given a good time, that ask the patient to make a wise decision in a controlled setting, and that's how the medicine is all about. We tailor-made our approach to the patient and family wishes.
Samin, I have received numerous emails. Some are citing a little concern about performing PCI here. One specifically I'll read to you. This comes from Lincoln, Nebraska, and it is stating that by our calculation, this comes as class 3B with the inappropriate criteria. How do I run it by my QA people?
Right. I think it's a very important point, and this is exactly what's done in this particular case. Once you have documented, the surgeon has written the note that this patient was discussed, all options given, and patient is still elected for percutaneous approach. So this is completely fine, and this actually, if you go with the ethical, clearly in the ACC the guidelines are clear that patient still remains supreme. Patient can decide. The only thing what we need to do is that we are not biased. That we are not biased, that we are not rushing the patient. And as long as the patient make that wise decision for various reasons, we have to fulfill the patient wishes. Now, we know in this particular case that leaving this patient alone, say, well, if we don't want to bypass, we don't want to do anything, to me that's inappropriate. But doing a PCI after discussion, after documentation is absolutely fine, and it is supported by the guidelines. They're not against you. In this case, it's a class 3, but we do many cases class 3, despite, I mean, this is all after the discussion. Yeah.
I think that's why the most important person in this case would be the non-invasive cardiologist, because the interventional cardiologist and the surgeon is out of the equation.
Yeah.
And it's the cardiologist with the patient have to make a decision. And why we take the patient out of the room is not just for patient to be out of the room. They have to be off sedation. Very important that the sedation that was given during Cath has been
some problems advancing the burr there?
Yeah. No, we don't have. We didn't get the pacemaker.
You should have it. 0.6 atropine. Now, clearly, many times we have seen patients with the left main and particularly RCA closure, they do get bradycardia and asystole, and that has happened in this patient.
So is the burr outside the left main there?
Yeah, no, it is just in the mid of the left main. I didn't leave it in the ostium.
Okay.
Yeah. So we are going to do two things now, because patients is fully anticoagulated on bivalirudin, so that if we can avoid putting a vein is fine, and give one neo also. But if it will become bradycardic, again get everything ready, right French and so.
We had it.
Yeah.
So many physicians doing this procedure exactly at this point will probably get too scared, back off from the rotablator and take a safer course of cutting balloon. Acceptable?
Yeah, that's acceptable. I think doing rotational atherectomy is not a must in this case. I think like as we discussed, nothing wrong in this situation that you have a balloon approach with the cutting balloon, or even if you have a high pressure balloon, go with a high pressure balloon. But the most important thing is the lesion preparation. You have to make sure in the cranial view that eccentric lesion has fully expanded before you go for stenting.
All right, what we have done now, we have primed with the atropine and gave a neosynephrine 200 microgram, and we are going
very
further.
slow.
No drop in the speed.
No, it will be okay.
No.
I'll try once more.
Okay. Yeah, no drop in speed.
Yeah.
Okay, Anu, just your good
went through.
feeling which you had.
Yeah, that it will be done slow. It has to be very slow and same. At any time you never push, the burr has to find its way. When we come out, right?
Yep.
Yeah.
It's so the patient has required just a single bolus, single dose of atropine.
Yeah, 0.3,
Okay.
not the entire 1 milligram.
How if somebody
300
could
microgram.
show us the hemodynamics?
Yeah, as soon as we come out, we show.
Yeah.
Got it.
Okay. So the electrocardiogram and so this
Looks good there. EKG is baseline. Heart rate is up nicely. Pressure is good.
And I think one important thing is in every situation, as we know, his EDP, he had an EDP of 14, so he already got lot of fluids. And important is when we give neo, we know they developed reflex, when you give atropine, also other thing is when they develop bradycardia. So I think nothing wrong in giving a little bit of neo and 0.3 of atropine and just get your hemodynamics
right.
Now,
ready.
some people will question here, Anu, that if you ablated with the 175, there should be really no need of a balloon here. Can you stent, or you want to put a balloon?
You have to have a balloon and a good expansion. That eccentric lesion.
Now, why had you not?
Balloon.
Why had you
does not
not
go?
decided to put a wire in the circ?
Now we put a wire in the
because
circ.
during the
Not via rotablator, it will cut the wire.
And what balloon are you planning to use?
Now we have a 3O. The thing was same. Depending on the length of the stent. You know, when you balloon, you want your balloon smaller than the stent size. If we wanted, we took a 15. I mean, the question was if we were going to go 23 or 20. So you could go with the 3O right now and see if a good expansion. If not happy, we may have to go 3.5 and always use a non-compliant balloon.
Sameer, many more questions have come, two which I'll read to you. Any role of FFR or OCT here?
OCT cannot be done in a proximal and ostial lesion because you need the entire vessel filled with dye to see anything. So when you're
FFR?
coming, FFR.
Yeah, I mean actually,
It's
you know
okay.
what? Even in the Excel trial, that once you have multiple lesions, they actually say you use IVUS or OCT. IVUS actually, and
IVUS or
FFR only
FFR.
for isolated lesion. Like this kind of case, even in Excel, but clearly there is a significant lesion. But if your lesion is 50 to
OCT.
70%, huh?
Not OCT in Excel.
No, not OCT. I'm saying IVUS. Yeah, that you can take the rotawire out. Yeah, that what it has been shown means if you have single lesion, FFR is good. Now here the question is what FFR is going to tell you. If, as long as the distal left main, you have the angiographically 80%. We confirm on the IVUS the lumen. What was the minimum lumen?
Now other thing also is just by when I'm wiring, I can feel so much of grittiness in the distal left main ostial LAD area. Just to tell you that there is, it's a calcific plaque.
So
But I just want to emphasize one very important point again, that this kind of case, there are not the typical cases, and this is not that we trying to do something which is against the rules, regulations and class 3. But yes, I just say that many times clinically we may need to do class 3, but as long as everybody is on the board, so that clearly from the QA point of view, that even this case is investigated, that because of the discussion, because of the documentation and the electiveness of the procedure, that this will be okay. Because key is that what in the past we used to have a much higher untoward event with the PCI in the left main cases, but that's no longer the case. So it's not the acute results. If you think about it, that we are doing it for the long term, acute we still have a lower event rate with the PCI compared to CABG.
So, another question has come. How much do you expect the cumulative event rates in this kind of a case?
Well, I would say that this case, because of complexity, usually the routine 6-month, 4 to 6 month angiographic follow-up has been eliminated by the recent guidelines, which is rightly so, because we don't get with a dual antiplatelet therapy and good results of the intervention, we don't develop those sudden deaths. So that routine, but complex cases, we do about 20, and so I'm going up. What is this? Which balloon is this?
Is a 3015.
Quantum apex?
Non-compliant.
Non-compliant.
Yeah.
Non-compliant.
Expanded quite easily.
Yeah.
Yes.
The 16
Should you want to
atmosphere.
check in the cranial view?
Yeah,
In
no,
that
that's
other case we saw the cranial, we never saw the expansion.
Yeah, you want to go to cranial view?
Yeah.
Because remember the eccentric plasma, we want to make sure it opened up in cranial view, that's where we see it the most.
Making a decision whether we need to go higher balloon size.
Or higher, or this one if we need to be, now we can go with the angiosculpt actually if we need, although it's nicely expanded. If you want, you can use a 3.5 angiosculpt.
So, with such exceedingly complex cases, is there a role of platelet function studies?
Yeah, that's another good point. We know the routine platelet function studies have not shown to be of any value, but in some case, we know that should you be doing it in this complex case, if we don't give a 2B3A, this kind of case routinely will do it before patient goes home next day if we are not given a 2B3A, or start the patient on stronger, reliable anti-DAPT therapy of whether ticagrelor or prasugrel. But in this case, patient is already on clopidogrel.
Yeah, he's on
Yeah.
clopidogrel.
Yeah. No, wait one second.
No,
Yeah,
don't
so we are
endoscope.
going with the same
if you
balloon.
need, you go higher pressure 3.5 regular balloon. Why?
No, but we need to do, no, but if we need to go to a different balloon, I think we can go 3.5 angiosculpt. If
So,
we need-
all your studies which you showed had compared first generation DES with the CABG.
Yeah.
What are some of the emerging data using the newer generation stents for left main?
Yeah, I think remember there is the data of the ISAR left main comparing the Zion everlumus eluting stent with the sirolimus cipher, and there was trend towards slightly lower stent thrombosis and lower TLR with the everlumus eluting stent, but about the same, and therefore and then there was one time the data of the cipher in Texas, and there was no difference. So I think overall, once you get to this large left main vessels, individual stent differences are less. Where it makes difference, in my opinion, this first and second generation stent will be for the multiple lesions. Yeah, when you have multi-vessel disease, multiple lesions, that's where you need a good stent which will have a lower MI and stent thrombosis, and that's where although we will not be able to repeat the syntax trial, all the freedom trial with the first generation stent, but we need to just go with those data. But I would say that whatever we have in the both syntax as well as in freedom, that will have a half the MACE rate in the DES arm if we would have used the Zions or any other everlumus eluting stent.
We may want to do it here.
Yeah, now see this here.
The ostium.
At the ostium of the circ, still there is a little disease.
Right.
You can have 3.5 angiosculpt.
Not 3.5.
Huh? Yeah, this is
3.25 flextome.
Yeah. Okay, 3.25 flextome.
So, both of you, Anu is preferring the cutting balloon, you are preferring the angiosculpt. What is going on in your mind when you are deciding for either of the two?
Yeah, just because it's just the ostium. If you see it, the under expanded area is that just the ostium of the circ. So you want a short balloon, and whatever the plaque is there, that's where you need an atherotomy to happen. That's why I wanted a flextome.
Anu, did you not reach that lesion in the circ, or is it more
we did. No.
angulation?
No, we did. There is a lesion there, so that once we are going to put a stent, we are going to cover that area also.
And Samin, what was your thought when you were thinking about the angiosculpt?
Mine is just to, because it may
High
require
pressure.
high pressure.
Okay.
Yeah. That's it.
See, with a flextome, you cannot, in the de novo lesion and at the ostium, at that level, you cannot go more than 8. atmospheres.
So at this point, what is your strategy right now? Are you going to first treat the circ and do that lesion, or?
Yeah, we are just going to do
So
the
right now we have
cutting
selected
balloon
a
of the
3.25 flextome, which is 6 millimeter
for the ostium of the
for the ostium of the
circumflex.
circumflex, because LED is nicely open. And then
No
we-
issue with the second wire there at this moment.
Yeah,
No.
the flextome, that's another good point, that while with the rotational atherectomy and the DCA, the side wire which contraindicated for the flextome or angiosculpt, you can leave the wire in the side.
take a deep breath.
We can open here, we can go up. Okay, I'm going up.
Oh, good. Wait, 1 second. Let me come back now. Yeah.
Yeah, that's okay. Let's make a room and it'll go up.
Okay. Wait 1 second.
Samin, another question came. If the IVUS
go.
does not show concentric calcification, will you consider not using? So the answer
No.
is yes, we will not be
Yes.
using it.
Yes, I mean rota.
Right.
No, I mean there's no question about
We
in
made
my
that,
opinion
yeah.
that this case, if anybody else is doing it without just using a high pressure or flextome or angiosculpt, is perfectly fine.
And there is already
Then it
somebody asking what is your preferred two-stent technique for distal left main.
Yeah, I would say since there is a both large vessel
So
and since involvement
kissing-
of both the
kissing-
ostium, so the
kissing
kissing
stent.
stent
Okay.
will be now. You can do other techniques of the tap and so. Yeah, do again.
now
Yeah,
this is
not open, no?
a good friend Carlos Nieves from Puerto Rico, San Juan, who's asking, would PCA of the RCA not make the left main intervention safer?
Down.
Yeah, that's another good point. We had a
thinking,
discussion.
Carlos, and
Yeah.
greetings.
Yes,
from,
Carlos is our good friend.
Yes.
Yeah, go back again. Yeah, no, I clearly in this particular case that from the RCA point of view, the reason was I think the discussion took place, very educated family, and the issue was the CTO, success rate, complication rate, and they felt after the discussion it was made that to do the left main and decide, say, the RCA on medically, because he probably had RCA CTO long time because he had a known ischemia in that distribution and LV function is normal. So that you're right. Ideally for full revascularization, we take a picture. Full revascularization, the RCA is, I would have done, if that was the plan, then you do the RCA first and then you bring back the patient for the left main, which definitely will make the procedure safer.
Everything looking good there.
Yeah.
Carlos,
That's
to you
Should
and
you
our
balloon it
friends
again?
in the
3.5, high
Caribbean,
pressure, no?
Felicidad Nuevo Años.
No? Okay, then what's the stent strategy now?
Yeah.
We're going
Okay.
with the
Now with the, if we can go back to the slide, we are going to show a new stent, which is the third generation, which has come, which is again cobalt chromium eluting stent and everlumus eluting of the Abbott, the Zions family, Zions V, the Zions Prime, and now the Zions Expedition. Now the stent design material, the drug dose and coating remains the same, but what really makes the difference is the balloon and the catheter technology. And where is the major difference is pushability, because they actually have changed the shaft so that you clearly have a nice pushability. And secondly, the balloon material, which is the multi-layer and a very little overhanging distally. And of course the tapered tip, so the profile is superior. So we actually started using for last few weeks, and we were the first one to insert before the end of last year. Clearly the Expedition gives you more flexibility, and from my point of view, better crossability, and you can go 16 atmosphere with this stent balloon, so that you don't need to post dilate, which we are doing in the earlier Zions family, almost every case or 80% of them. Here you need to post dilate maybe only 30-40%. And very good stent, and we'll try to show this here by using two stents, using both are
3028 we go to the LAD.
yeah.
And what do you think, 3.5 to the circ?
Yeah, and then I think there's a large vessel. We can use a 3.5 and 3.0. The circ will require a longer stent.
Will it turn 33?
Yeah,
Not like a
33.
turn.
No, 33 will go. Yeah, there was 3.0. I think but actually, if you want, you can do both 3.0s.
So we are
Okay.
virtually
Both 3.0.
seeing the entire case being showed.
No,
series.
I need a circ first. You need a 33, 28?
33.
I think 28
Huh?
I just make it. I don't know, circ.
Huh?
Okay, 33, man, not
Yeah, 33. Circ we are going to use a 33.
You're trying to get that lesion also?
Yeah, exactly.
The second,
Zionist
yeah.
expedition.
Yeah, I think you need a 33 at least.
Yes.
That would be my thought.
The same thing is, since the circ we knew was you try to get the circ strand down first.
Samin, here
Yeah,
is
that's a very important point which Anu just made, and I want that put the stent in a more difficult lesion first when you are using a two-stent approach. Actually, when I moderated in TCT at that time, the relay from London, we told them that put a stent in the circumflex first before going to the LAD, that left main. Now, of course, they were trying for the LAD and then try to put the circ, and nothing went. I said, well, that's it. Then they had to take it out, went as we mentioned before, and then case was done. Yeah, you're saying something?
No, this is exactly what Anu had
Yeah,
felt.
that
it's going to
33
be.
will not make a turn. Sir, deep breath.
You want to slightly deep throat the guy? Yeah, there you go.
I'm doing that. Means the other question, we may have to double wire, get
Right.
the stent
Or
down.
we do a high pressure.
Did we have to do a high pressure?
Yeah,
That-
no, I think the circ you could
There
still
it
do a little
goes,
more high
there-
pressure.
there it
But
goes,
see, this
yeah.
is a
Deep,
great
deep breath.
pushability.
Deep breath is the key.
Key and the pushability. That's okay.
Now,
not for-
what you do is same. Try to get your stent way further down. So now you'll be able to get your LED stent.
Breathe
without-
normally.
right. Breathe normally, sir. Breathe normally. Yeah.
Yeah.
And same when you're trying to push the stent. Okay, we just I keep telling them, not like you are doing a car wash. Just slow, progressive push.
Yeah. And the key is that I think the part of that is the pushability of the expedition really comes handy in this particular case with this angulated and able to show that 33 made a very nice turn in this moderately calcified, which you saw that required another high pressure balloon before we could
So, which cases in your practice today are you using this cobalt chromium
We need to do half
new
and half,
stent?
because the guy may be coming.
yeah. Now, in terms of I mean it's basically in our lab we have all of them available, and the Promus element, the resolute integrity, as well as of course now we have the Zion's expedition, but clearly the based on our personal data and our own experience, the with Zion's family stents are the preferred, and they actually makes it a majority.
Anu, why did you take the stent in the LAD distally there?
No, no.
It's
What
just
I am
that.
when I was trying to get the circ stent, I think the LED stent went
Okay.
forward.
All
So
right.
now I think adjusting the circ stent is a key here. So some die.
Yeah, it's way
so I know
too
how much
distal
I
there.
need to come back. Yeah,
Yeah, you need to be.
yeah.
Yep.
I think LED is in a good position, but I think every time I try to get the circ to that level, okay, yeah,
Yeah.
that's good.
And then put the LED.
You
Now
need
key is the
to-
dots, both dots have to come identical.
Proximal markers have to be exactly
Yeah.
overlapping.
Yep.
So, both these are the expedition stents?
Yes.
Yeah, but you see that both dots are equal, but they are not close to each other, because left main is bigger size. If you see that, I
No,
think
but
I
you
can
want-
go further with the LED stent.
Right, slightly more to get it.
One dot, 1 millimeter. And the stent is exactly at the dot,
Starts at the marker.
at the marker.
Okay, some die now. We are good.
That's fine. You went a little too much.
No, no, it's good. You
Yeah,
want to
looks
pull back
alright.
both?
Yeah. No, that's okay.
I think too much we don't need. Okay,
Huh?
you good? Happy?
Yeah, but LED I wanted to bring 1 millimeter back. Good. Okay.
Okay, good.
Okay, we are going up now. Go to 10 atmosphere. My fellow here,
Jenny.
Jenny, is going to 10.
Okay, down.
10 seconds negative.
Samin, how is the patient tolerating this?
Very good. Blood pressure is good, but you can always make sure you give neo and have your blood pressure high.
So, did you
We
give
started
neo?
with 140. I just told the nurse give a bolus.
And then
So it went down to 120 just after the inflation. It's
and,
just,
and this
yeah,
is the
just-
16 atmosphere inflation in the LED stent.
That is step number 2.
2.
Yeah.
And then you see the balloon is still there. So clearly in these cases you are a little fast, so that deflate. Some people use a half and half die. I personally don't, but I think using a half and half die for a rapid deflation is no problem. Go up 16 now in the circ.
And this is the time I think
Step
you need
3.
to, yeah.
The fourth one.
Okay, looks to have expanded nicely at the ostium.
Okay, down.
Yep, negative.
See, the pressure is 140, and as when we are inflating is go down to 120.
Yeah, okay, we are going again. Both at you actually can go 12 and I'll go 10. You're 12, right?
Post at the circ.
Yeah, we may have to dilate.
Yeah, down.
At simultaneous deflation. Good.
Yeah, that's good.
So, without seeing it angiographically,
do?
how do you
3.5.
think the carina is going to be?
Carina will be okay, it's just
About-
at a circ ostium. We may have to post dilate there. We are already asking for 375, 15 and
Yeah,
there are 3.
3.5. Yeah, 3.5 we opened 3.5 earlier, but take one by one out. Yeah, 3.5 we opened because we were thinking to pre-dilate the circ lesion, and we had 3 earlier anyway. So we have both of them with us.
So, Samin, here is a question of the day for you. I'm going to read it exactly.
Okay.
Which
Copy, sir.
stent is the best for unprotected left main in 2013?
Well, I would say based on say PVC wire.
No, yeah.
No.
We just heard a little.
Hold the wire. Take the balloons out.
I think I just roughed up ostium.
Well, I can tell you now, until if you would have asked me this question before the expedition came, because clearly the Zions, we are very good and good results, very low, almost no late stent thrombosis after 1 year, and so an acute great results. But had some problem in ostial in the Zions in the ostial left mains because the recoil and so. But now with the Zions expedition, if you ask me in 2013, what is the best stent? Clearly, from my point of view and by personal experience, I would say, not supported by any data randomized showing that superior or so, but personally will be the Zions expedition, because ostium also is doing great results very nicely and good expansion, and as I said, that majority of the time you need to post dilate.
What
now.
would you use if a left main is 5.0?
Yeah, I would basically use a 4.0 and post dilate, and this actually we had done with the using expedition and post dilating with up to 5.0 balloon. 4.0 you can go one extra millimeter.
Angiographically looks pristine.
Yeah, ostium is
Even-
still a little bit. Oh, sorry.
You think so? I mean, it's maybe we should take a LAO caudal view to see.
We are going there now. The ostial circ, should it be dilated?
Looks very good to me here, but let's
right
see.
now, yes.
Can't make out much in this view.
And then we go to the last one.
The distal lesion looks very nice in the circ. I think you got the stent there exactly right.
Yeah. All right. Okay, Anu, tell me what you want to do.
I think we still post dilate the. No?
Again, going with your gut feeling, how you saw the expansion there.
Yeah.
So you'll probably use a 12 millimeter.
15. You need a 15.
Okay.
Yeah. But same, you are using 15, use another balloon in the LED also.
Yeah. 3.5 circ.
So
You
we're going with the.
You don't
3.5.
think it's bigger than a 3.5?
No, circ will be okay. No, but remember now they will be both combined, ostial circ in that area.
So no, okay, got it, that's fine.
Yeah, and 3.0 will put in the LED because you have to have both simultaneous.
You see a nice step down in the cranial view in the left main without any dissection.
Anu, what's going to be the follow-up for this patient?
Clinical.
Good. You want to bring angiographic follow up this patient or no? Good. Yeah. Go to the other one now. I mean, I would, but this case, actually knowing that has still moderate disease distally also, and we are done, and relatively, now question besides having complexity, second point for me to come angiographic follow-up is, if there is a choice in the patient, you know, some patients who are non-surgical, I think probably no need to do angiographic follow-up even in complex case. But if the patient could have option like this case, surgery could always be an option, can be re-talked, again, that I have a low threshold of bringing them back for angiographic follow-up in the complexity.
What would you be deciding about the RCA?
I think
I
that
think
is based on the
yeah,
discussion, right?
discussion has happened, how he feels, but patient wants the total occlusion opened because he's a very active guy.
Okay, what is it?
No, it's not
You
going.
need a new balloon. Look into new balloon if this does
Why
not go.
this is not going.
Yeah.
Looks like it is somehow.
Are you on the same shaft?
How? I'm in the circ.
Yeah, 1 second. You hold the wire.
No, I
Hold
have
the
the wire.
Which try to pull this wire which you are going on. Is it a circ wire or LED wire? That's what I'm
No,
saying.
that is not the circ wire. The other balloon is in the circ.
Samin, another very practical
LED.
question.
Get a new one then, right? Yes. Yes.
If there are some people doing such complex cases, you would normally recommend 2 senior people scrubbing in together in such cases?
I would say that that's where the problem is. Okay. Yeah.
No, I'm
that,
in the.
okay. That this is kind of case that you definitely need 2 people, and particularly if one junior person is there who is few years out, you definitely should have a senior person in the room. But having a 2 senior, and this is where we plan in our lab, and part of our low complication rate is because of always these kind of high risk cases selected, thoughtfully discussed, and 2 interventionalists, one of them being a senior in the room and helping out, assisting in every way. Now clearly I think this is the wire crisscross versus the deflated balloon did not go, so we are going with the new balloon.
Right.
And went in? Okay. Good. Keep holding. Bring both of them at the same. Now, the key is the length could be different of these balloons and size could be different, but key is that proximal pointer has to be the same, like here before we go up.
A
See that?
true kissing balloon
kiss, yeah.
strategy. Okay.
Yeah, go.
How high are you?
I'm going 20. You can go 16. Yep.
Down.
These are what, quantum apex?
Down.
Okay.
I think you have to do the carina a little bit, no? Or we're good?
No, that's good. We did it now.
Okay.
Yep. And we pull back and take a last picture, and we are done by getting to our 60 minutes mark.
Ostium, leave it, right?
No, no. Austin, leave.
Some dye. This one.
Take everything out. Right? Huh?
You are okay with ostium?
Yeah, yeah. Ostium will be keeping out. But now we have to engage it. We are taking the last picture with the
Both the wires out.
both wires out.
Okay. A little nitroglycerin or?
Yeah, that's it. Little nitro. We have done the good job with the stent, with the metal. Now with the chemical metal, with the nitroglycerin, and we take the pictures. Good. Yeah, there is a now actually the ostial, the circ is definitely a better expanded.
And angiographically, you are convinced no need to go back with the IVUS?
Yeah, it is completely fine. Very good results. Fantastic. With that note, let me come back to my end points here quickly. That is the take-home message. That is the long-term data of coronary revascularization for complex, multi-vessel, and unprotected left main CAD clearly favors CABG over first generation DES PCI and should become the default therapy by guidelines. Clearly, the question you asked, what will happen if it would have been the second generation stent? We don't have the answer to that. But the more importantly, whatever we have, that's what we have. So heart team discussion about management of these patients should be routinely done by to come up with the most preferred strategy. Once revascularization is contemplated in these complex CAD patients, assistance by a senior expert operator could be useful. So very important, all these points put into the guidelines and discussion with the patient. Now I'll take quickly the 3 questions. That one is the long-term follow-up of left main subgroup in the syntax trial in patients with high syntax score showed the following in favor of CABG over Texas DES. The significantly lower death MI-CVA, significantly lower TLR, significantly lower MECI, significantly lower MI, and significantly higher CVA.
PRE.
Second question. Following patients population will not be appropriate for heart team discussion. where we talked about heart team discussion is for complex cases. The multi-vessel disease in a diabetic patient, 3-vessel CAD with syntax score of 18, distal left main bifurcation calcific lesion, multi-vessel CAD with syntax score of 31, and 3-vessel CAD with long calcified CT of LED and RCA. So clearly the answer should be very clear. The last one is the following are the trials of the unprotected left main CAD except the syntax trial, the pre-combat, the Lehman's, and the freedom. Clearly, if you put those questions, it's an additional CME, get the CME points and so. Yeah.
Anu, final words from you and Samin. I also have one more, a more difficult issue to speak with you.
Sure.
Maybe let's get this issue out of the way and then we'll take the final comments from Anu.
Yeah.
How, one of the concerns I have is our viewers watching this case. I mean, you've both got more years of interventional cardiology experience than probably most people on the planet. What should be the word of caution? Somebody shouldn't be. I don't want to let this message go that some novices should be trying such cases.
Well, from my point of view, it's very simple. That yes, everybody, the stents have really leveled the playing field. But some cases, we still need to concentrate and to the experience center. So nothing wrong in your regular practice that you send these cases to a center which can do them effectively, and then patient comes back to you. So clearly, what has happened over the years, why we continue to grow, that many of our cases comes to us by interventionalists because they know that complexity, they could do it also. With nothing, it's not that they cannot do it. But point is the time it will take, efforts it will take, send it to the center where it is the kind of a run-of-the-mill machinery, and this is where the message will be that the complex cases, if you are an interventionalist doing a 200, 250 PCIs, these kind of complex cases probably should not be attempted unless it's an acute emergency. But stable patients then should be sent to a referral center where you have a good confidence and get the good results, and of course it ultimately pays back to you. Reason is that you follow those patients and they continue to remain in your patient population.
Anu, final words from you.
I think I just want to focus on one thing, that the question that came up, that how do we face the QA and ethics committee of the hospital, and we have been through this thing. As long as you have a protocol that's written in the cath lab, signed by the director, saying how this kind of complex cases should be approached, which are class 3, 2A, 2B or class 3 indication by the guidelines, that patient was informed, interventionalist, cardiologist and the surgeon, everybody discussed, and a note written that the best treatment option for this patient would be to do PCI, and all the risk benefit has been discussed. If a protocol is already there and just start doing those cases, knowing that even if something that 0.5 to 1% chance that something happened, that it was done by the books and the protocol was followed, that way that this kind of complex cases can be attempted by interventionalists in the cath lab.
Anu, excellent job, beautiful skills, great illustrations. Congratulations to you and to your team for another outstanding case. A few dates for our viewers. Later this week, January the 23rd, join us for peripheral interventions with Dr. Prakash Krishnan, and our next session will be February the 19th. That would be session number 44. Samin, any last words? Do we have a picture of your team?
Yeah, actually all our team members come here, while also just to add on that we added another feature with the CardioSource and ACC, that as a part of the presentation, that additional CME activities, the 2 articles which are related to the EES in a left main as well as syntax 3 year, that's a CME exercise which will be available on the CardioSource as a link to the today's presentation, and viewers can go through that CME and get additional credit besides going for this archive case. Ongoing live CME, still we are trying to get it, but so far CME can be obtained on the archive.
So you can get 2 hours CME by the archive session and review of this additional material.
Absolutely.
We have your team. Some are hidden behind the mask. Who do we have?
Yeah.
We have Paul, we have Pablo, and we have Ramon. Paul is the nurse, and other two are the tech, and of course I have Jenny, who is my interventional fellow, who is going to be assisting me in all the cases today in room 2. And Tuesday is our complex cases day. We have at least 3 CTOs lined up and a couple of bifurcations.
Anu,
And
good.
just one more the thing which you ask. We also starting this month that in our ACC webcast, our case with the cardio source, I will recap in 2 to 3 minutes at end what was the highlight of the case in terms of the stent, the drugs or the combination and what I presented and what Anu did, so that there will be an additional highlight of 2 to 3 minutes at end of the case will be also available, and that will again, so people just want to know what was done today. So that 2-3 minute presentation and then links to the full 1 hour session.
Excellent, Anu. You have a long day ahead. Go ahead, order dinner to be brought in, and we'll see you next time. Another fantastic case.